Hello guys, let's discuss few essentials on stroke imaging. I'm the AI voice speaking behalf of Dr. Abu. Modalities for imaging in stroke vary between different institutions. MRI and CT are the two main workhorses to identify and characterize the causes for stroke. Imaging, identification and early intervention plays a very vital role in the survival and better outcomes in a patient with stroke. Remember, time is brain. Main aim of the imaging is to identify 1. If it is a stroke or just a stroke mimic, for example, hypoglycemia, tumor etc. 2. If present, if it's due to hemorrhage or due to ischemia, if ischemic. 3. If ischemic, to identify the salvageable area of tissue, that is penumbra, and the dead tissue, that is the core. 4. To look for major vessel occlusion for further endovascular management. Coming to the CT-based protocols, you perform a non-contrast CT. 1. To rule out any bleed in the brain. To see the signs of ischemia, dense AMCA sign, disappearing basal ganglia sign, insular ribbon sign. 2. To see the mass effect in order to decide for decompressive craniotomy, craniectomy. You perform a CT angiogram. 1. To look for major vessel occlusion. Major vessels include ICA, M1 and M2 AMCA, A1 ACA, basilar artery, vertebral artery P1 and P2 PCA. 2. To assess collateral status, good collaterals, good chance of ischemic tissue returning to normal after mechanical thrombectomy. You perform a CT perfusion, to look for the penumbra, tissue that is salvageable, and to look for the dead tissue, core. Advantages of CT is that it is easy, cheap and fast. Disadvantages of radiation exposure and contrast requirement, which is a problem in patients with CKD. MRI-based protocols include 1. Perform a DWI to look for diffusion restriction, indicates infarct, cytotoxic edema, with corresponding low ADC values. DWI can pick up stroke as early as 2.5 hours. 2. Flare to see hyperintensities, if present, indicates a stroke of more than 4.5 hours duration. 3. Susceptibility weighted imaging to see for blooming, bleed, and vascular susceptibility sign in ischemic stroke. 4. Head and neck time of flight angiography, TOF, imaging to see for major vessel compromise, non-contrast sequence. 5. ASL imaging to look for perfusion, it gives RCBF values. 6. DWI-ASL mismatch gives you the penumbra. Advantage of MRI is no radiation exposure and contrast requirement. Disadvantage is motion artifacts. Some important terminologies. 1. Early ischemic changes, changes of ischemia on imaging when presented less than 6 hours from the onset, and acute infarct when presented after 6 hours. 2. RCBF indicates the rate of blood flow in a unit mass of brain tissue, expressed in milliliter per minute, 100 grams. 3. RCBV indicates the amount of blood present at any time in a unit mass of brain tissue, expressed in milliliter, 100 grams. 4. Mean transit time, time taken by the blood to cross from the arterial side to the venous side of the brain. These parameters are invariably altered in stroke and are used to differentiate between penumbra and the ischemic core. Aspect score is score of 10. You subtract points from each part of the brain involved. Single points are scored for the caudate nucleus, the internal capsule, the lentiform nucleus, the insular and the cortical parts at the gangliocapsular and supragangliocapsular levels. Less aspect score indicates a severe stroke. In the PC aspect score for posterior circulation stroke, we subtract the points according to this displayed image. This is a pictorial diagram to define core and penumbra. Infarct core has low CBF and CBV values. Penumbra, which is a dying brain tissue, has low CBF but normal to increased CBV values. This needs intervention to salvage it. Medical management of the stroke includes administration of recombinant TPA, which is Altplace. Endovascular management or mechanical thrombectomy is an interventional procedure to patients presenting in stroke window, which is within 4.5 hours. Now coming to the AHA criteria for selecting patients for MT, these include 1. Age. Patient should be greater than 18 years of age. 2. Pre-stroke misses should be 0 to 1. 3. NIHSS score should be between 6 to 25. 4. Aspect score should be greater than 6.5. Major vessel occlusion, involving ICA and M1 MCA. Coming to the reasonable indications with uncertain outcomes, these include 1. Elderly age, considering the life expectancy, say for example a 95-year-old female. 2. Breaststroke misses greater than 1.3, NIHSS score less than 6 or greater than 25.4, aspects less than 6.5. Major vessel occlusion involving M2 MCA, A1 ACA, P1 P2 PCA, basilar and vertebral arteries. Now coming to the mechanical thrombectomy, it involves mechanically aspirating the thrombus. Mechanical thrombectomy can be performed if all above criteria fit and patient presents within 6 hours of onset of symptoms between 6 to 16 hours. Diffuse trial is followed where core is less than 70 milliliters with ischemia, core ratio is more than 1.8 and difference between core and penumbra is at least 15 milliliters between 6 to 24 hours. Dawn trial is followed. The criteria for Dawn trial is displayed as you can see on the slide. These are different devices used in mechanical thrombectomy. First generation device is the Mercy coil. Second generation one is the penumbra aspiration system. Third generation and presently preferred device is the stent retriever. This is an image taken from the web showing the stent retriever retrieving the clot.